Welcome to another EMCT-sponsored podcast on the topic of onboarding in emergency medicine. By onboarding, we aren't talking about HR issues such as contracts and benefits. We're talking about that education and training that's needed for new providers to provide safe and effective care in the emergency department. We want to recognize those groups and organizations that are the pioneers in developing these new guidelines for their providers. And the American Academy of Emergency Nurse Practitioners is one of those organizations we'd like to highlight today. We would like to talk with a board member from AAENP, Brad Goettl, and let's join that conversation now. Welcome to this EMCT podcast on the topic of emergency medicine onboarding and education in emergency medicine. I want to welcome Brad Goettl from Texas, an emergency nurse practitioner and board member of the American Academy of Emergency Nurse Practitioners. Welcome, Brad.
Hey, thanks for having me. Totally excited to have this conversation with you. Like I said, my name's Brad Goettl. I am a doctorally prepared nurse practitioner. I'm triple boarded in family, acute care, and emergency nurse practitioner. Prior to becoming a nurse practitioner, I was a longtime ER nurse and flight paramedic. And so I've been taking care of emergency patients in some capacity for the last 20 years. I am here in Dallas at UT Southwestern, where I'm the Assistant Director of Advanced Practice, maintain a clinical practice at Parkland, which is one of the busiest emergency departments in the country. And so that's quite a pleasure to work there. And yes, I am a board member for AAENP and have been on the board for now going on 3 years. And will be the next president-elect in January.
Oh.
So excited to be here with you and have this conversation.
Well, congratulations on that president-elect status. That's very great. That's great. So you kind of answered part of one of my questions, which where you're at now and kind of your journey. But that's really where I wanted to start. The traditional path for PAs and NPs and even physicians going to work in emergency medicine has been to gain an interest in emergency medicine, begin working it, and then work your way into the practice and all, and get those legs under you, or get your chops, so to speak. What did you do or when did you become interested in emergency medicine? And then what did you do to prepare? And was it the traditional on-the-job training or mentorship kind of role?
Yeah, so I'll say that my interest started way back when. My dad said I used to watch medical TV shows while, eating, SpaghettiOs in the living room. He always thought it was a little weird to watch medical shows at a young age. So I'll say that I had an interest in some sort of medicine young, but one of my grandmothers was a nurse and an EMT, worked in a rural ambulance service where they still drove in a hearse. And when I went to college, I lived with my grandparents instead of living in a dorm. And so there were a lot of tales that were told in the living room. And I'm like, you know what, I think this is something I could do. And I wasn't really sure which direction I was going to go with college. And after kind of having some of that, exposure, I decided to do the EMT route. And I would say that I kind of took the long, non-traditional, became an EMT, an intermediate, a paramedic, an associate degree nurse, and a bachelor's degree nurse. And, kind of, we'll call it lifelong learning or just kind of little steps along the way. But yeah, and always worked in the ER. I actually took my first EMT course in high school. I remember riding the ambulance on prom night instead of going to prom 1 year. So it's been a long time in the field, and honestly, not really sure what else I would do. I think it's definitely like once you're in for life, one way or another. So that's been my journey.
So where was the first place that you worked in the emergency department after you?
Yeah.
I imagine you graduated from an NP program somewhere and then went right into the ER, or did you go to the clinic first?
Well, a little bit of both. So one of the attendings that I had worked with when I was a registered nurse opened up an urgent care center, and he kind of took me under his wing, mentored me, became my supervising physician. And so I worked full time in that urgent care, and then worked kind of part-time or PRN in the group that covered the ER where I was working as a nurse. So I was able to kind of do urgent care and emergency room right out of NP school. My NP program was a very unique program for its time 10 years ago. It was an emergency focused program that was inclusive of a family, acute care, and emergency and a doctoral program. So it was just shy of 4 years long with a lot of clinical time and a lot of clinical time in the emergency room and critical care areas. So I would say that not all programs look like that, but I think it definitely set me up for success. I would also say that while I was in NP school, the hospital where I was working as a nurse started a new residency program, brand new. And they took me in kind of like their little duckling and let me come to a lot of lectures, and there was a lot of good mentorship, and it was a good environment because they were building a training program. And then I, was already familiar with the faculty and stuff. And so I felt like I had a good foundation there.
Do you know what percentage of NPs work in the emergency department or do acute care offhand?
I don't know percentages, but I can say that off the last AANP kind of self-reported data, there's about 26,000 nurse practitioners in the country that report working in some sort of emergency care, which could include urgent care at self-reported. So it's hard to say exactly a percentage, but a pretty good amount.
Okay. Yeah, and there are about 360,000 or some nurse practitioners, so clearly less than 10%.
Yeah.
And as far as opportunities to go to large volume facilities like in the ED, in the past, I mean, that's really been the track, right? I mean, you graduate, if you want to do emergency medicine, you want to go somewhere where you're seeing lots of volume, just like emergency trained physicians want to. And you want to gain that experience. Are those opportunities still there for new grads that want to do emergency nurse practitioner route? I mean, are they able to get into a larger facility to get that training?
Yeah, I can give just kind of some anecdotal experiences. Every region will have different hiring patterns. Of course, as somebody that hires advanced practice providers, I would love that every candidate had, 10 years of experience in high volume places and were able to hit the road running. That's not the case. And if that is the case, you may not be able to afford them. So we do occasionally hire new graduates. It takes to work in a large volume place that's moving, a couple 100,000 patients a year. It really takes a special new graduate that is going to be a person that's going to go and learn on their own, read on their own, learn procedures, maybe go to resident conference when they're not required to, and do some extra things that are going to make them really strong in their decision making, and that they're willing to ask for help. There definitely are environments that I think are more conducive to new graduates, and I know that emergency departments do hire new graduates, and I would say that the ones that do, I hope that there is an onboarding program, or that they're hiring people that have specific qualifications or experience in emergency medicine. It can be a little harder for a new grad to find their spot, but like we always say, you have to start somewhere. And so if you can't land a job straight in the ER, think about other areas that manage acute care patients or patients with acute complaints. Like correctional medicine is a great, place to see all kinds of stuff. Urgent cares. I think of all the places where you do unscheduled visits, really could set you up if you don't have the traditional kind of ER experience. That could set you up for success for landing an ER job.
Yeah, for sure. Unfortunately, sometimes the only opportunity is in a low volume rural environment. And I was a previous chair of ACEP's rural section, and then chair elect for a couple of years before that. But we saw that the standard really, or the norm at low volume rural emergency departments, and there are frontier departments, we call them affectionately, but
Mhm.
they see less than 2,500 patients a year. Clearly not your Parkland ER.
Yeah.
There are some that see less than 4,500, half patient an hour, we're looking at. And then there are those that start to see, more, like the 8,000 and more. But in the very low, or in the lower volume, the 4,500 or less, in those EDs, the norm is becoming for PAs and NPs to work there independently. And unfortunately, sometimes that's the only job available, and that becomes very dicey. And I really respect the NPs for coming forward nationally. And I saw Jen Wilbeck was on a paper as well that indicated that out of your NP program, you're not prepared to work in the emergency department. And it sounds like AAENP really has that as a mission to really help to create that minimum standard to be able to practice in emergency medicine. And it becomes even more important when you're a solo practitioner, since in about half the United States, you have independent practice status. And the standard that we found in interviewing, or actually I should say sending out surveys to the rural task force, of a most recent ACEP rural task force, was in a number of listservs that we sent out, the standard currently for getting credentialed at a rural emergency department was that you needed ACLS, ATLS, and PALS, in addition to your NP or PA license. And clearly that's woefully inadequate to practice in emergency medicine. And so I wanted to talk to you about, where those educational standards are and how they're evolving, and what AAENP is doing to help, improve patient safety for these patients in those low volume emergency departments.
Yeah, I think, well, definitely, we all have the same mission, right? We need to provide, good access to high quality care all across the country. We could all agree if there could be an emergency physician in every ED in the country, that would be great. But for some reason, we've not been able to get there. And I'm going to guess that for many of the reasons that, board certified emergency physician might not want to live in a very small town is probably the same reason why APP might not want to live in a very small town. It takes a very special person to work in those areas. They have to really connect to their community, physician or nurse practitioner or PA. They really get embedded into the lifestyles of those committees. So we know that it takes a special person to want to work in resource limited areas. But we also know that sometimes that's where you're going to get your first go at a job because there is such a demand to cover those facilities. And AAENP has really done a lot of work to raise the bar. And I'll say, as an organization, we are about 10 years old. Our nurse practitioners have been working in EDs long before that, but really as a specialty or as a focused area of training, we're fairly new. And if we look back to when emergency physicians evolved, and out of other practices, and kind of got your own specific specialty, that evolved over time too. And so what we've done as an organization is not only develop emergency nurse practitioner core competencies with other professional organizations, we've standardized those core competencies, and we have updated them. In the early years, there were two sets of competencies from 2 different professional organizations, and most recently, I'd say the last year or so, that the organizations came together to standardize those competencies. And those competencies really serve as a blueprint or a roadmap for academic programs. We are starting to see more academic programs, so we're seeing universities see a demand for education in this space, and as a specialty, they weren't widely regulated. They weren't necessarily that one program looked like the other. And so AAENP worked with the certification board, and now only programs that are validated by the American Academy of Emergency Nurse Practitioners qualify for the certification exam, and they meet a rigorous set of standards, and they go through kind of a double review by surveyors and content experts to make sure that their training programs meet certain standards and meet certain objectives. And so that has evolved probably over the last 3 to 5 years. And so now if you graduate from an accredited or a validated program, you can qualify to sit for the certification exam, and then that certification exam can be proof that you kind of met those standards. There is the ENP core curriculum. It's been out 2 years. A nice resource for nurse practitioners working in the emergency department, for faculty and training programs, or somebody that just needs to pick up an additional resource. So I mean, that was a long time coming. Most of us are authors in that book. It's got a lot of good stuff in it. And then this fall and the spring will be the National Scopes and Standards, which will be a publication that's coming out this fall. We just started to see the proofs come through. And the editors on that are Wesley Davis and Diane Evans, both experts, emergency nurse practitioners.
Yeah. And the ACEP Rural Task Force, we came to the conclusions in 2020, tried to create some standard as well for non-EM trained physicians, PAs, and NPs to work solo in rural emergency departments. And basically, there are 5 recommendations. One, that there would be some kind of foundational training in emergency medicine. 2, that there is airway training and experience. 3 was more of a team-based or scenario-based training where you'd go through simulations, that sort of thing. 4 was working in a high-volume facility for a period of time, and that would be dependent on that NP or PA's or physician's previous experience, that sort of thing. And the last thing was telemedicine support to be available. Additionally with that, what we recommended was that you have an emergency physician medical director to make sure that the hiring is of those individuals that have those standards before they work in that environment. Now, the political climate as well. And it'd be great. ACEP has helped to create a lot of your education or worked with you to help create certifications in the past and all. And I know as you guys have a great relationship. ACEP stopped short of creating an actual standard. And you're in the evolution of creating that standard as well. SEMPA is in the process of creating that standard. The American Academy of Family Practice has, endorsed family physicians working in emergency departments, and they actually have a certification process through the American Board of Physician Specialties, a BCEM certification, board certified emergency physician, but none of those are necessarily standards. So there is a condition of participation for rural emergency departments to, the first condition of participation is that you have to have proper equipment. And by proper equipment, they mean everything, all resuscitative equipment and down to IV catheter and a Tylenol or aspirin. You got to be prepared for for all emergencies. Under the second condition of participation is that you have to have emergency medicine trained providers. They can be NPs, they can be PAs, or they can be physicians, but they need to be EM trained. But that's where it stops. It doesn't define what that is. The reason why I bring that up is because every health system, every contract management group that I know of, every rural hospital struggles with this process, and many have tried to reinvent the wheel themselves and create, some educational support. Some don't do anything. They're just like, look, we need someone. Here's the best experienced person we can find. They got a license. We're going to put them in there. And so there are standards that are just across the board. So I appreciate AAENP stepping up and helping, for nurse practitioners anyway, help create some support, because it's not fair to take an individual that's not trained in an environment and put them in there when they have no idea what kind of line or minefield they're walking into. And that's really hard. I mean, as an emergency resident, I moonlit. And it was anxiety provoking being on your own, not entirely trained. I felt good about it. I had taken 2 anesthesia rotations and done a number of intubations. So I felt I had that in my back pocket, and I felt I could take care of sick people. But there's so much to doing emergency medicine that it really takes, years of experience and a lot of academic rigor to become prepared, particularly in a low resourced environment where, you may have to depend on staff that aren't as adept as at your high volume facility as well. So anyway, I just was just throwing that out there that they struggle, and can we lean on AAENP perhaps to come up with recommendations for those facilities and hospitals?
Yeah, and I think that you bring up some good points. My very first job as an RN was in a very small town of about 700. We had 2 ER beds, and if you were the nurse for the ER and the med-surg unit at the same time. So I am intimately aware of the struggles. I have, since went to work at very resource heavy facilities, but I remember nights being the nurse on call while the physician was at home sleeping, because it was only 8 blocks away. They could stay at home. But you could have, somebody roll in the back door that was on the verge of having a cardiac arrest, or maybe a baby that arrested on their way in too. And, a lot of times you were stuck, initiating those resuscitations before the physician could get there. And this was me working as a nurse, not even a nurse practitioner at that time. The one thing that I'll say is that solution or emergency care is a team sport. We all kind of agree with that. But the solutions can't fall in one independent silo. So I'm glad that ACEP has invited us to the table to be a part of some of these conversations. But it really does take a village to make these type of guidelines and recognize that all professions need to have an equal voice at the table, because we're all a part of that solution. And so it doesn't necessarily help if one organization makes a set of standards and the others don't fall in line, because we're all looking out, and kind of taking care of our own profession also. And I think that the more and more we work together, and like I said, ACEP has invited us to the table on a lot of stuff, that I think we really kind of push the needle forward. We drive the train in the right direction, and we get to, improve care across the country, and recognizing that not every hospital is going to have, broadband internet and access to telemedicine, or not every frontier hospital will have all the equipment, although we would love them to. And money doesn't grow on trees, and workforce is expensive, as is equipment. So, but I think that, as long as we're able to all work together and kind of drive this change, I think that, we'll continue to see improvements in emergency care. And AAENP does want every nurse practitioner in the United States that's taking care of emergency patients to have specialty training. We believe wholeheartedly that they should, not even rural areas, but all areas. I think that there's an evolution of time where we're going to see that emergency care wasn't a part of traditional academic programs many years ago. But as we move forward, I bet you that's what we'll see in the future.
How common are the fellowship or postgraduate training programs for NPs? And are there some that are just for NPs, or are they more broadly for PAs and NPs?
Yeah, I think that they're probably equal for both NPs and PAs. Our training program here, our postgraduate certification program that we have here, we accept both nurse practitioners and PAs into that program. We accept 2 every year. And so it's a small class. It's not a solution to a workforce of 26,000 people, but it is a partial solution. And these programs are popping up all over the country. They also range in rigor too, and they range in the types of experiences. I think as programs become accredited to the various accrediting bodies, that we're seeing standardization and in those training programs. I'm proud of our graduates. They come out of here, seeing a lot of acuity, high volume, really good at pattern recognition, and working with some of the best faculty in the country. So they're coming out of these programs incredibly prepared to be strong nurse practitioners and PAs wherever they choose to practice. And I think that a lot of the programs are very similar in that regard. I would love to see that pathway grow. But unlike physician residency training programs, there's not federal funding for those programs. So they tend to be homegrown, home funded, sometimes funded through other grants or, university development projects or some other things like that. But, there's no federal funding really for those types of things specifically.
Do the graduates tend to stay in the ED at Parkland, or do they tend to go to another high volume ED? Is Parkland part of a larger system? Do you have a network of rural facilities that refer into that it needs to staff?
So good question. So Parkland is our county facility here in Dallas. They are part of a health system, but a single hospital system. Okay. But they do have a lot of outpatient resources. We are employed by UT Southwestern, which is the academic partner to Parkland. And so we provide the physicians and APPs to the ER there. And we have an adult university hospital in the medical center, also a University of Texas hospital. And then our fellows also do time at Children's Health, which is also in the medical center, which is kind of our pediatric partner in Dallas. And so it all really depends on where we are at and our workforce needs. So if they graduate and we got a full load, then oftentimes they look at other hospitals in the region. I would say the majority of them stay in the region. So we're very proud that our training program, just like physician training programs, will kind of, feed really strong candidates to other hospitals in the region. We have some that went a little further. We have a couple that are at Vanderbilt and elsewhere. And then there's a good chunk that have stayed because we've had, openings at the same time that they're graduating and it made sense for them.
Okay, cool. So, on a different note, being an NP is not being a nurse anymore. You are diagnosing, treating disease, and in many instances working independently. Would it make sense, and I'm just throwing this out and just spitballing it, but would it make sense to have NPs get credentialed on a statewide basis through the medical board, a state medical board, instead of a state nursing board? Or does a state nursing board make more sense, because I guess you have NPs there? Does that make sense?
Yeah, I see where your question is. And I think, in an idealistic way, it kind of makes sense that you are, prescriber now, and that body is used to regulating those things. However, it is a different profession, and the state boards of nursing have, regulated the nursing profession, including advanced practice nursing, all across the country. And so I would say it is what it is. I don't see a model where that changes. I do think that there needs to be, very close collaboration between the two. But in most states, advanced practice nurses are regulated by the boards of nursing. And in the guidelines, have carve outs for specific scopes of practice regarding advanced practice nurses. So it's not like you're trying to fit something into an RN model. In the state of Texas, you have to maintain your nursing license in order to be an advanced practice nurse. So I guess you're always a nurse once you become a nurse practitioner.
Yeah. It just seems that when issues arrive with regard or come up with regard to licensing, having a nurse review it. And I learned this, I thought when I was in residency, I thought we were all on the same mindset that there was, a medical model we all followed, and we're all thinking about diagnosis and treatment. And I was told by a nurse manager one time, no, there's a nursing model. And, this is holistic care, and we care about, the patient's response to their disease and to pain and that sort of thing. I'm going, really? And then I talked to my nurses in the emergency department. They're like, no, we're more interested in what you're doing with diagnosis and treatment.
Yeah, I'll tell you.
So the ideology from managerial and people working clinically can be quite different.
Yeah, I mean, I'll give you that for sure. So, when I teach, NPs in the program that I teach in, I'd say, hey, although you're a nurse and you're always going to be a nurse, and you need to remember your foundation, and you need to remember, what the state boards of nursing say regarding your practice. Take a lot of that information and set it aside. And now you need to learn this other model, because you're going to work in an environment. You need to speak the language, and you need to learn pattern recognition, and you need to figure out what a differential diagnosis is. And you need to be able to work through a differential and, understand diagnostics in a whole new way, and be able to present a case to a faculty or a physician in a way that they're going to understand it. And there definitely is a different model. And it's important that, NPs remember their roots, but it's important that they also are able to speak the same language as their colleagues and can make decisions in the same way also.
Yeah. No, I've been onboarding PAs and NPs since, early 90s. I brought them to our emergency department when we had about a 30,000 volume, and it was kind of a tipping point where we needed, more providers, particularly going into the night and early morning and that sort of thing. And so we added that coverage in busy evenings. I learned, the backgrounds of PAs and NPs, particular, and new grads we hired, and we tried to hire people with experience. Doesn't always happen. But what I always tried to enforce was understanding the underlying pathophysiology of the condition, not just a pattern of behavior of your mentor, but really understand what it is, because sometimes phase 1 DKA protocol isn't the best first step for someone in DKA when they're really sick. There might be other priorities that you need to address first, and that sort of thing, and stroke protocols, that sort of thing. But let's take a look at each individual patient and understand their particular condition. And that's right. A real shift in mindset from someone who's an emergency nurse. And we've had many of our nurses go on to become ENPs, and they spend time with us and work, and you can kind of see the light come on, like, this is the diagnostic side. And it's just got to be it's got to be exciting to have that amount of experience, but then to have that shift in mindset as the person actually making the diagnosis, just not responding to a diagnosis that's been made, but getting the differential and all.
Yeah, when I work with novice nurse practitioners or trainees, there is a light bulb moment, like you said, and they see it, and I feel like sometimes you're like, man, I've been an ER nurse for 20 years. Every chest pain, we do these things every single time. And it's like you automatically get into this patterns of behavior, like you said, or this is the way we've done it, this is the way I've seen it, this is the order set, this is the task, not necessarily like the decision. And then when they understand that this process is actually easier, it's easier to formulate a differential and a plan and get from point A to point B in a methodical way than to try to remember all of those tasks for certain complaints. And it's really fun when you see a trainee pick up on that.
Yeah. Well, and to know when to pivot, to a different path of care, depending on the patient's response or continued deterioration or their improvement. There've been many times I've been set up to intubate people, and you go back and it's like, oh wait, they're responding, to whatever therapy you have in place, and let's hold off and all. So, but being on that side of it, as a nurse, I'm sure you're like, I thought we were going to go down here, now what are we doing, and then you get it on the provider side, and you're the one that's having to, rethink your process going forward and all. So no, it's got to be an exciting time, but it's really a payment in time that you have to make in order to get your chops, to be able to function in that environment. So, and certainly you have that advantage at a high volume facility at Parkland to become a better and better NP over time. And in emergency medicine, it's got to be tough, for people in rural to start there and to see that low volume. But you get used to your low resourced environment as well, I guess. But even more, there needs to be some supportive education and all to help so they can learn from the mistakes of others and their experience of others, and have that telemedicine support as well.
Yeah, I think any level of support is better than none. We all agree more education is better. I mean, no doubt, right? And without that information, it can be a scary night in those resource limited areas.
So maybe, I don't know if this happens. I imagine it happens. Individuals reach out to AAENP for information on education. But if we direct health systems your way, and say, look, we need to staff our emergency department, high volume facility, or we need to staff this moderate facility. There's only one other physician there. But, it gets busy at times, and there are times you're going to have to, really step up. That physician isn't always going to be there available to you. And we've got this really low volume facility that we need an independent practitioner to work there who's solid. Are there recommendations that you think AAENP would give now, or recommendations coming down the line that would help these health systems, contract management groups? I mean, that's really what people are looking for in the end.
Yeah, I think there are. So one, they can reach out to us through our webpage, and we'll figure out who the best kind of expert to meet with them is, even if it's just to have a conversation. And it's not uncommon. We've met with payers. We've met with, big contract management groups. We met with state boards of nursing. We as an organization are small but mighty, and we're happy to meet with anybody and give some recommendations. On our website is a toolkit that is great for health systems to pull down, medical directors, credentialing bodies. It's broad. It's it's kind of the 30,000 foot view of this profession and the competencies, what it looks like on licensing and certification and stuff. It's a great place to start. That toolkit will have a version 2.0 as we've heard feedback from our stakeholders on information that needs to be in there. So we're happy to give those resources. The core curriculum is a great place to start. The scopes and standards when it comes this fall will really help a lot too. So those are good resources. And then also, like I said, one-on-one meetings. It's important for these big groups to realize that each state has its, a little bit of a different focus or like a little bit of a different view. And so it's important to understand kind of what the local rules and regulations are. And we may not always be able to speak to every state's requirements, but we can usually get a hold of somebody. We have state representatives that are good that can help with that information too.
Yeah. Well, I think it's important for all NPs to know, whether you're a new grad or a veteran, that ENP or the AAENP resource is highly valuable. And membership in the organization is what gets growth, drives that growth, and drives more resources as well. And I know of a lot of our emergency nurses that have graduated, gone on to be NPs, and work in our high volume facilities, or go to other facilities and gradually work their way to rural, when they feel that they've got confidence. And I'd say, well, are you a member of AAENP? And some will, well, no, I haven't joined that, or what's that, and so I'll educate them. But I tell them, look, this is your body. This is what, who has your back and who's going to be your resource. This is not something you have to go down alone and forge your own path and figure this out on your own. You've got a group of colleagues that can help you through this process. So it's great that this organization has come together as that resource.
Yeah, it's evolved over 10 years. It should have been here a whole lot longer, a long time before that. But, it's a grassroots organization. People built this organization and have been advocating for, practice change, standardization, competencies, curriculum. All the stuff that is driving our profession forward is happening through, professional organizations. And we serve as a professional home for emergency nurse practitioners and allies if others feel like they'd like to join. But I think that not only is it great to be a paying member, and that definitely helps grow the organization, but we have a ton of opportunities for people that want to get involved in changing their profession or driving change in their profession. So if you're a new grad and you're working in emergency care or want to, and you want to be a part of the organization, but you would like to be a part of our practice committee or our education committee, or, maybe you're really good at social media, there's a lot of opportunities to be engaged and, really kind of help drive the profession forward. And there's a lot of academic folks that are within the organization that are doing a lot of this building of the foundation of kind of the academic-y side of stuff. But we'd love to see all the practice folks too that can translate all that stuff to the bedside. And so if people want to reach out to me on LinkedIn, or I'm not really on Twitter, I'm probably more active on LinkedIn, or they can message us through AAENP. We can try to get people plugged into their areas of interest and help grow the organization.
Yeah, no, hats off to you guys for taking that on. I'm sure that the numbers of emergency nurse practitioners were small initially, and you had to wait to get to a critical volume. It seems that emergency medicine and acute care NP practice is expanding. My recollection is that initially there were only about, 3% maybe at best that did emergency medicine. And it looks like that percent of overall is growing. So the number of ENPs must be growing. And so I think there's an opportunity to growth for AAENP as well.
Definitely. Well, I mean, just like emergency physicians are finding different places where they're working, and it's not just in the four walls of an emergency room. Yeah. Emergency care and unscheduled care is being provided in your living room now via telemedicine, in an urgent care, in the back of an ambulance. I mean, programs like Vanderbilt and some other flight programs have, nurse practitioners on their helicopters. And so we're seeing that kind of the amount of people that say I'm emergency nurse practitioner is growing, but so are the practice environments. And as emergency physicians grow to those areas, they're, we're going to grow with them because we are going to work side by side with them in those areas. And so I think that we'll continue to grow as a profession. 26,000, I would say, is an understatement, because that's probably only the people that replied to the survey. So
Right.
I'm going to guess that there's a whole lot more.
I'm sure you're right. Is there a requirement yet, or is that coming to get acute care certification to do acute care medicine, like urgent care and emergency medicine?
Yeah, so language is important in nursing. So acute care, meaning that somebody has an acute illness that needs to be managed. We do manage those things, but in the nurse practitioner world, there is an acute care certification,
Right.
one for adults and one for pediatrics. And in some environments, people with those certifications also work in the emergency room. However, they don't have an across the lifespan certification. So we do have family nurse practitioners with the emergency nurse practitioner certification that allows you to manage patients across the lifespan. And then we have acute care certifications that it's really based off of the population that you're certified in. So we do have an emergency nurse practitioner certification exam. There are 3 entries to that exam. One is that you have maintained successful emergency practice for some period of time. You've done additional kind of professional development in emergency care. You've done procedure courses. You've done some other CME type stuff, and you have the practice hours. So that's kind of the one pathway. I kind of view that as kind of the grandfathering pathway. But then there's the pathway of I've completed a traditional academic program specialized in emergency care. That's one pathway to take the exam. And then the other one is currently that you could complete a fellowship program that's been validated or accredited. You can, in emergency care, you can use that practice time and that kind of academic preparation and qualify for the exam. So those are the 3 pathways for the emergency nurse practitioner exam right now.
And with evolution, it looks like more and more health systems are recognizing the value of that additional training and the need to have providers that have additional training. And I know that they had and still have a variety of pathways, or much like what you're describing, say, within the Mayo system. But more and more, they're taking their postgraduate training, emergency medicine trained PAs and NPs, and putting them in their frontier or very low volume EDs because they're available. There's more and more of them graduating from the program, and it looks like a lot of these programs kind of earmark for those individuals to go to those facilities. And you can't put handcuffs on them, but you can encourage them, and maybe you can do loan repayment or signing bonuses that that they have, they get, but it's a loan, and different ways that you can encourage people to go to those environments and work there. But everyone that goes there wants to feel that they're supported, and they don't want to feel out of their element. And that's where the telemedicine support certainly is crucial, and being well trained to begin with. So
yeah, I mean, if you want to burn out somebody and have them leave your organization quickly, don't offer opportunities for development. Don't offer a support. We know from survey data from Press Ganey and Glint and our own kind of HR stuff that as long as people feel like they're supported, they feel like they belong, they have opportunities to develop, they're likely going to be a long-time loyal employee. But you have to provide those things. So that means that, and we didn't really talk about it a lot. We talked about all the mechanisms to kind of get certified, but onboarding is important. Even if somebody doesn't go through the traditional fellowship or certification or whatever the language of the week is, program or an academic program, if you are hiring people that don't have that training, then health systems, institutions, contract management groups, so whoever the employer is, do need to invest in their orientation and making sure that they have all the resources they need to be successful. That investment up front saves you in a lot of risk management in the back end. So it's important for that to happen.
Yeah, that's such a great point, Brad. It really is. Onboarding is an expensive process, even if you're looking at just the raw dollars alone, to have a new NP come in, work for 6 months or a year, burn out because you put them in an environment that they weren't prepared for, and they recognize it and leave, that's probably cost your organization $250,000. Really, by the time you have to bring someone in, recruit, wait that time, staff that ED because that person isn't there. I mean, the tangible losses that you can measure, not to mention the intangible losses. So not even just the medical liability alone, but the true loss of dollars. Investing money up front in that education, in that onboarding, get them comfortable with their practice, let them get their legs under them, and feel comfortable, let them know they're supported by the organization, is just so important before they go out and practice. And it's a patient safety issue as well. So all around, there's just huge benefits in a good onboarding program and education and in support ongoing.
100%. And I think that your dollar guess is pretty close to what I've actually seen in the literature, about 300,000. Not only for all the things that you brought up, but as you bring people on, they're not as productive. So you have loss of revenue and productivity so it's like there's so much loss by having your staff turnover, including the morale of the other staff.
Oh, right.
Because it can start a spiral really quick, and that door starts, spinning, and people, and you just don't want that if you keep a good environment, keep a good culture. I think the big thing about culture is not only, but, it goes along with belonging, but is that really good relationship between, all the team members, that I feel like I can come to you with a complex case, and you're going to listen to me. And then and I feel comfortable doing that because you didn't ever put me down for having to do that, or that you're available, in those times, and vice versa. You need me to, pick up the slack on some stuff too. You feel comfortable coming and talk to me, and that collegiate relationship really helps build a strong emergency department. And when it feels very hierarchical and stuffy, people are scared to ask for help, and so I think that building those relationships across team members is really important.
No, well said. Well, good. Any last comments you want to make from AAENP, or anything that I missed that I didn't touch on?
I thank you for the opportunity. We have great partners at AAENP, and so you've been one for a while. So we appreciate that partnership. There's definitely a lot of opportunities for professional development, and if your particular employer doesn't have the resources, reach out to us, because we have great partners that offer educational programs, that offer adjuncts to academic programs, and then of course all the publications and resources that we have out. And I named some of the big ones, but there is a library of academic papers that have come out that can help guide your credentialing office, can help guide conversations about scope of practice, can help guide relationship building. And if you need those things to have informed conversations with your team members or your employers, reach out, because we're happy to be a good partner and get that stuff to you.
Yeah. Oh, and the credentials committee and recommendations is important. A lot of these facilities have gone, traditionally they had family physicians that were pretty well rounded in their training, but needed some additional training in the most acutely ill patients. And so they needed ACLS, ATLS, and PALS for resuscitation and have some guidance for those acutely ill patients that they wouldn't normally see in their practice. That has carried over in that tradition now for all providers, and there needs to be a revamping of all of the credentialing to be an emergency provider based on what that person's background is. And ACLS, ATLS, and PALS is obviously woefully inadequate, and so starting there, even with recommendations for health systems and rural hospitals, would already be a big plus.
Yeah, and the only last thing I say is, be humble, know your limitations,
right,
and be aware of your own scope of practice, because not every physician, not every administrator, not every credentialer knows what the individual nurse practitioner is capable or licensed to do. And it's up to that nurse practitioner to really know their boundaries and know what's in scope and out of scope. And so we're happy to have those conversations with folks too. And it looks different from state to state. But I always tell new folks, just because it says you're allowed to do it on your hiring paperwork doesn't mean it's really within your scope based off of the state boards of nursing. So it's important to be very, very aware of your scope.
Yeah, very well said. And I really respect the AAENP for having that approach and having the resource you do available. So terrific having you here, Brad. Thanks so much for joining in this podcast. We have a series of podcasts on onboarding, again, with our PA colleagues, physician colleagues, and others, and look forward to starting airing these. So appreciate you coming on.
Great. Thanks for having me.